Good morning, everybody. Welcome to our weekly medical grand rounds. As you can see, tomorrow is National Orange Shirt Day. And just, a reminder that it has been 10 years since Orange Shirt Day was declared, but 3 years since National Day for Truth and Reconciliation was recognized. And so there are all kinds of activities going on tomorrow. Whether it's through Alberta Health Services or through the university and the institution, ways of recognizing what Truth and Reconciliation Day means. And I think it's particularly important that we in the medical profession and as educators take the time to really truly understand what the day means, whether it's reading about some of the stories or hearing them. They can be really powerful and poignant, and just taking the time to reflect what we can do to meet the calls to action. So hopefully you'll get the opportunity to do that tomorrow. So with that, I would like to respectfully acknowledge that we are located on Treaty 6 territory, a traditional gathering place for diverse Indigenous peoples, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saulteaux, Anishinaabe, Inuit, and many others whose histories, languages, and cultures continue to enrich our vibrant community. It gives me great pleasure today to introduce Dr. Muba Taher, who is one of our graduates from the University of Alberta. He also completed his residency in dermatology here. He is fellowship trained in most micrographic surgery, reconstructive surgery, and cutaneous oncology from the University of California, Los Angeles, and the University of Southern California. He is currently a clinical professor in the Department of Medicine and an active member of the Division of Dermatology. He maintains a special interest in skin cancer management, including the prevention and treatment of skin cancer in organ transplant patients. He is medical director of the Edmonton Dermatology and Skin Surgery Center, which is a non-hospital-based surgical facility. And his presentation today is going to be skin cancer burden in solid organ transplant patients. So over to you, Dr. Taher.
Thank you very much, Dr. Kassam, for that introduction. For disclosures, I have one disclosure. I have received honoraria for advisory board participation on a PD-1 inhibitor called cemiplimab, and I do talk about this in my presentation. So several weeks ago, I was walking through the lobby of our hospital, and I saw this sign on organ and tissue donation, and two big thoughts struck my mind. Number one is that it's truly a miracle that we have patients who've had an organ transplanted into them, and that keeps them going. And secondly, I realized I better get to working on my PowerPoint presentation. Grand Rounds is coming up. So I've put together the following for us today. Number one, I want us to understand this burden of aggressive skin cancers that these patients have to, a lot of these patients have to endure. Secondly, I'll share with you some images on recognizing some of these cancers in your patients and our patients, especially the bad ones. And to be aware of the different strategies that we can use to help manage this risk in all of our patients. I looked at global data on transplantation, and it continues to grow. In 2022, more than 150,000 patients across the world received a solid organ transplant. There was a little dip during COVID, but we're coming right back up again. I was interested in local data. What's going on in Alberta? So Alberta Health Services kindly provided me this data. And you can see that in 2022, we were busy. We did almost 500 transplants in Alberta. The renal teams led the way with 261 transplants. And as you can see, the other numbers there as well. Compare that to almost a decade ago, where we were closer to 333. On a minor footnote, as a dermatologist, I couldn't help but notice that they did not include hair transplants in this. So this success of organ transplant is a result of the many advances in transplant medicine, including the use of immunosuppression drugs. These same drugs that help preserve graft function in our patients also have the undesirable effect of dysregulated immunity. Some of these drugs themselves are inherently mutagenic. and this contributes to skin cancer, along with the complex interplay of other factors, as you see there. So when you talk about cancers in these patients, squamous cell carcinoma dominates the conversation. Skin cancers are the most common neoplasms in the solid organ transplant recipients, and cutaneous squamous cell carcinoma is indeed the most common. These patients endure a more aggressive disease course compared to the general population. I would like to tell you about squamous cell carcinoma and its aggressiveness in terms of its incidence, the multiplicity of tumors that these patients get, the risk for local recurrence, nodal disease, and metastatic disease. This is data from a large database, a multi-center retrospective cohort study of almost 10,600 transplant recipients across 26 transplant major centers in the United States. And the authors wanted to establish what is the incidence here in the United States. They recorded incidence in terms of rate per 100,000 person years. And as you can see, you can compare the incidence rates in the transplant patients versus the general population. Based on this data, squamous cell was 36 more times likely in transplant patients. Malignant melanoma, 14 times more likely. Merkel cell carcinoma was 23 times more likely in these patients. This is data from a cancer registry in Norway. They keep tight records there. And this looked at 50 years of data, almost 50,000 patients. And they wanted to see how squamous cell behaves differently in different aspects, transplant versus non-transplant. And when you look at the risk ratios, you see that there's more than 4 times likelihood of transplant patients having a multiplicity of tumors. Metastatic disease was 1.5 times more, and death from cutaneous squamous cell carcinoma was recorded as being 5.5 times more. Estimates would say that up to 40 to 70% of all transplant patients will eventually develop skin cancer, and this burden seems to go up with time. Yeah, the U.S. Western data would say 10 to 27% in 10 years, 40 to 60% in 20 years. This prospective study that followed a group of transplant patients over 22 years showed a rising incidence with time. So we get a sense of how serious these cancers and prevalent they can be. Let's have a look at some of these lesions that come through into our clinic. So I'm going to talk about, limited to just 5 lesions. There are so many we could talk about. Let's talk about actinic keratosis, because this is a potential precursor to squamous cell carcinoma. I will talk about squamous cell carcinoma. As we've just seen, it is the most important in terms of incidence and morbidity. And then basal cell carcinoma is just so common, and we should know about it. And 2 other cancers we'll discuss will be a melanoma and Merkel cell carcinoma in terms of presentation. Actinic keratosis, this is a pre-malignant area of dysplastic keratinocytes. These usually present as pink scaly spots on the usually sun-exposed areas of our patients, and they can transform into squamous cell carcinoma. If you ask me, well, what's the risk of an individual lesion turning into squamous cell? That's a very difficult number to quote. I usually tell my patients, some of these, not all of these, we just don't know which ones can transform into squamous cells. So we like treating as many of these as possible. So here are some images from our textbooks of a patient with scaly, rough patches in photo-exposed areas. Sometimes they're subtle and hard to see. They're just a little faint pink patch, and they're sometimes better felt than actually seen. In photo-exposed areas, you can see these thick, rough patches, as you see on the scalp and arm. I had this renal patient come in and say, I have these sunspots that are getting thicker. They're beginning to get a little tender. Those are good flags that perhaps these actinic changes are now progressing into squamous cell carcinoma. We have to be careful when we look at the field to make sure we don't miss those thicker, crustier, more painful spots that are evolving. When actinic keratosis diffusely involves the lip area, you can get scaly, sometimes sore patches, and we call it actinic cheilitis, and we don't want to miss squamous cells on the lip. That represents a high-risk site for a local and regional spread. Sometimes they form these thick horns. We call them cutaneous horns. So what is the relationship between actinic keratosis and squamous cell carcinoma? If you look at this diagram, you get dysplastic keratinocytes forming in the upper layers of skin. When it's just a few layers, we start forming actinic keratosis. When it's full thickness epidermal involvement of these irregular cells, we start calling it squamous cell carcinoma in situ. And when it gets beyond the epidermis and into the dermis, we start getting into invasive squamous cell carcinoma. So squamous cell carcinoma is indeed the most common malignant neoplasm in these transplant patients. They come from the keratinocytes, as we saw. They have worse outcomes, and they have variants, some more aggressive than others. So here are some examples of squamous cell carcinoma in situ. They can present as these faint pink patches, maybe a little bit scaly, and then you watch out for, are they getting thicker? Are they progressing? When we get a pathology report that says squamous cell carcinoma, we hunt for more details. We need to know more. In this example, this is a head-on cut of a nerve in the dermal tissue, and you can see these cells wrapping around this nerve, and that represents perineural squamous cell carcinoma, and that is an adverse prognostic finding in these patients, and we look for that in our path reports. It can signal subclinical spread of these tumors. Here you see what we call poorly differentiated squamous cell carcinoma cells, also a flag for aggressive tumors. And depth, a lot of these staging systems factor in the depth of these tumors as well. Here is a combined renal islet patient who came in a few months ago with a rapidly growing nodule on his right ala. And this was a squamous cell, that crusted raised nodule. We removed this tumor with Mohs micrographic surgery, and you can see the defects of the wound after the tumor is cleared. Here's a patient that presented with a tender, enlarging, erosive nodule at the mucosal lip extending onto the cutaneous lip. We excised this and repaired it, and had a good result functionally and cosmetically. We got there through using micrographic surgery. We tracked this tumor with a microscope in our office. We had a final defect that extended into the underlying orbicularis muscle, and the area was reconstructed locally with a combination of cutaneous and mucosal flaps there. This was a case I did about 12 or so years ago. This transplant patient had a lesion at the sideburn area. It was well covered by his hair, so he didn't think much of it. He kept waiting and waiting to bring it to the attention of his doctors, and eventually it was getting quite large, a little bit painful, a little bit erosive. By the time we saw it, it looked like this, and this is him after he was reconstructed. We required head and neck surgeons to provide the reconstruction, because when we did Mohs micrographic surgery, there was quite a bit of subclinical spread. He did have perineural disease, and this was one of the later cases that I did. I think we were at the office till 11:30 p.m. tracking his tumor out, and we had to keep going because his OR was at 6 a.m. the next day. This is an unfortunate patient of mine that I looked at after about, again, 7 to 10 years ago. He was an example of a patient on long-term immunosuppression who kept popping up these tumors, and it was in an accelerated fashion. He would come in, there would be a few more, we'd cut them out, there'd be a few more. It was an ordeal for him. We had to keep an eye on him. He endured a lot of biopsies. We would do micrographic surgery, in many cases leave the wound alone to heal. Other times we'd stitch him up. Unfortunately, with his accelerated rate of tumor growth, this led him to radiation therapy on the scalp. You can see him enduring that there. Did well after that. Unfortunately, he had recurrence. He had these subdermal nodules, which turned out to be metastatic squamous cell carcinoma, developed lymphadenopathy, and unfortunately, he succumbs to his cancers, his skin cancer. Back in those days, we did not have some of the novel treatments that are available now, including PD-1 inhibitors. This is a patient, heart transplant patient, that I keep a very close eye on. I see him like every month or two, and within one of these interval periods, he developed a enlarging plaque on the neck, as you see there, and He required urgent referral to ENT for excision and repair. This is a heart transplant patient with a nodule on his lip. Mohs surgery tracked this tumor right into the mucosa. Plastic surgery helped us with the reconstruction. He's had multiple other excisions, including multiple tumors on his ear. I'm happy to say he's still doing very well. I saw him just a few weeks ago, and he's very happy with his prosthetic that he now wears. This is my latest bad case. Just saw within the last few weeks, enlarging plaque on the nose. Unfortunately, he's from out of province. He was referred to me. He has a bad squamous cell at the nasal region. I put those arrows there because if you palpate the tumor, it tracks along his nasal sidewall and is bound down into his bony structures. He's been seen by ENT, and I spoke to them, and he's going to need rather significant morbid surgery to excise this. He's being reviewed by our colleagues in the Cross Cancer Institute for possible immunotherapy with PD-1 inhibitors, radiation therapy. We do PET scans on these patients, and these are very challenging cases. I'm going to now transition to basal cell carcinoma. Again, this is the most common cancer in the general population, and we see them in our immunocompromised patients as well. You see the classic pink pearly lesions with rolled edges, surface telangiectasia. These have low potential for metastatic disease. However, we're cautious because they can cause extensive local invasion. Here's your classic basal cell with the surface findings. Some of these variants are very aggressive and have subclinical spread, such as this morphiiform basal cell carcinoma. This is a referral. You can, if you look carefully, the patient has had an incision in the area before. By the time I'd completed tracking this tumor, it was a bit larger with subclinical spread, and we repaired this with a graft from the clavicle area. This is a basal cell that tracked right into the nasal cavity, as you see there. A discussion on skin cancer would not be complete without talking about malignant melanoma. This is a neoplasm of melanocytes, significant potential for morbidity and mortality. Organ transplant patients have an estimated 2.5 to 5 times higher risk of melanoma. And I think many of us have heard the ABCDs of melanoma: asymmetry, border, multiple colors, larger diameter, and the historical evolution of the lesion enlarging and changing, as you see there. I tell my patients about the ugly duckling sign. You know, I say, look at your lesions, pick out the one that's different than the others, and take a closer look at it, and get your physicians involved to help you out if you're uncertain. Recently, in the press, unfortunate passing of a celebrity, and Merkel cell carcinoma got some press there. Merkel cell carcinoma is an aggressive primary cutaneous neuroendocrine carcinoma, significant risk for metastatic disease, 3 to 10 times more likely to develop in our solid organ transplant patients. There's an association with polyomavirus, and workup and staging can include sentinel node biopsies, resection, radiation, immunotherapy. So this can be a very aggressive tumor. Now, if there's anything you remember from the last several slides, it's that watch for, on your patients, lesions that are growing, that are crusting, that are bleeding, causing pain. Encourage them to have these assessed, or direct them to those who can help. Further assessment is necessary, including likely tissue biopsy. So we've looked at how some of these cancers present. Let's talk about things we can do to help our patients in terms of photoprotection, skin cancer screening, and some pearls on treating them using topical, surgical, and systemic approaches, including immunosuppression modulation. So UV radiation exposure is the most common and important modifiable environmental risk factor for these patients, and we can help them modify this risk. There's the usual common sense discussion about the clothing, wearing long sleeves, perhaps accessories like hats and glasses, and using sunscreens. I tell my patients, you can still have fun in the sun, but be mindful of these modifications, and pick your time going out there. Maybe a little bit earlier in the day, or after the sun is beyond its peak. There is strong evidence that sunscreens used regularly do decrease the the rates of skin cancers, basals, squamous cell carcinomas, and melanoma. Unfortunately, there's also evidence to say that a lot of our transplant patients don't routinely use sunscreen. We try to remind them on a regular basis. So this study, prospective study, looked at transplant patients over 24 months, those who did and did not use sunscreens, and the counts of actinic keratosis came down, as well as the counts for squamous cell carcinoma formation. So we do encourage our patients to use sunscreens. So what do you want to tell your patients about using photo protection? I tell my patients to use sunscreens that are water resistant, use sunscreens that have a broad spectrum coverage. So look for the UVA and UVB designation on the bottle or tube. There's a metric to figure out the protective factor of a sunscreen, and I say look out for that number 30, SPF 30 or higher. Apply the sunscreen 15 to 20 minutes before your sun exposure outing. I remind them to apply this every couple of hours and after they swim or they towel off, or if there's a lot of sweating, so to use that. I personally tell them to use mineral sunscreens. They less chance of reaction than some of the chemical ones. Another pearl is to use about a teaspoon in every body part, an arm, and a leg, face. And we encourage them to use hats, ideally a 4-inch wide brimmed hat. The baseball caps sometimes don't catch the other parts of the head. We talked about UV protective clothing and remind them every time. So this gentleman's has a nice wide brimmed hat. Unfortunately, he has other risk factors like smoking for other issues. Back in 2010, I made it to page 24 of Alberta Cancer Foundation Leap magazine. So we used to do these skin cancer screening events at public places. We went to the baseball park, legislature, and we'd have these booths. We'd have a skin cancer awareness and sun protection awareness. We'd go into these little tents, and me and the nurse would look at the photo exposed area. So it was a good campaign sponsored by the Canadian Dermatology Association. So screening is important. Studies do show that annual dermatology assessments after transplants do help reduce cancer morbidity and mortality. Now, the reality check is with the increasing numbers of transplants, as you've seen, it's unlikely that our current dermatology workforce could perform skin cancer screenings universally on all of these patients. So the goal is, who do we prioritize? Who do we screen? And when do we start screening them? So to address this question, first of all, current guidelines, there's many different recommendations. There's really no consensus, and there hasn't been strong evidence to support one or another. Now, as a common sense rule, obviously, if the patient has a lot of skin cancers, you want to see them more frequently. So as far as who to screen and when, there was a nice study done in 2019 looking at a useful tool to help answer this question. So they used that same database that I referred to earlier, where they looked across 26 transplant centers, about 10,500 transplant patients, and they looked at risk factors and came up with risk calculations. So they looked at these 5 factors: age greater than 50, male gender, thoracic organ transplant, that is heart or lung. These patients usually have higher immunosuppression needs. Pre-transplant history of skin cancer, white versus non-white, and they came up with a score and risk categories. Now, why did they pick these? Because in our literature, we have many reports that these are the factors that really contribute more so than others for a risk of cancer. So they looked at these numbers. Just to quickly run through this, they took risk factors, came up with hazard ratios, point values, used those point values to get risk categories. And based on risk categories, they would say, for example, the low risk group, you have a 1.66% of getting a skin cancer. For the very high category, you're up to 66%. So we have a tool to at least tell us maybe who's at high risk. They came up with recommendations. Now, if you're low risk, that 1.66, really, you don't need to be surveyed on a routine basis for the first 10 years. On the other hand, if you start getting into medium and high risk, they should be screened by 2 years, by 1 year. If they are high risk at the pre-transplant stage, they should be screened even before their transplant goes. This is a screenshot of, so they turned this this calculator into an app. I think if you go to the App Store and you'll see this. It's SunTrack 4 TXP, something like that. I downloaded it and I took a screenshot of trying this on one of my patients, Caucasian, age greater than 50 at transplant, no history of prior cancer. It's a female. Heart transplant, so we'll pick thoracic. Based on this, you see the calculator generate a 5-year risk at 15% of skin cancer, 10-year risk at 31%. So this patient's considered high risk screen within a year. So it's a tool. Now, like all tools, you've got to tweak it. You have to look at the patient, the individual, the anxiety level, other factors. But it's something to at least help us figure out who in the crowd there shall I focus on. I'm going to move on to treating these patients now. I will talk about topical, surgical, and systemic approaches here. So we have what's called liquid nitrogen cryotherapy. We spray these pesky actinic keratoses with these pressurized liquid nitrogen in the office. It stings, it hurts a little bit. I tried it on myself. And when these patients have a lot of these actinic keratoses, you don't want to spray them 100 times. So we have a cream for everything. So in this case, we have a lot of topical chemopreventive agents. The common ones and the ones that work well are 5-fluorouracil and imliquimod. And we have photodynamic therapy as well. So this is an example of a patient who's used 5-fluorouracil. And you can see after treatment, they have a lot of redness, scaling, and it can be a little bit sore. You have to encourage them to endure this, and it can help clear up a lot of these precancerous lesions. They will need treatment from time to time. Some of my patients come in and say, "Oh, it didn't work," and when you really push them, you find out they didn't use it properly. A typical course might be use it twice a day for a couple of weeks, with the caution that if it's too excessively irritating, cut back a little bit. I've started telling my patients that I want to see a selfie of your worst day of using this, and hopefully that will help with compliance. Here's a patient who actually overused the imliquimod that I asked him to use, and had more inflammation and crusting than I intended. However, it helped clear up his spots there. Photodynamic therapy is an in-office procedure that helps us treat the field of actinic change, like the creams. It can be handy for patients who don't want to go through those several weeks of applying. Maybe they're not comfortable applying it. So in photodynamic therapy, you take a photosensitizer. We use levulinic acid-based products, and they're applied on the field of photodamage. And the photosensitizer preferentially settles in on the slightly higher metabolically active precancerous lesions. They incubate in the office. And then we expose them to a specific wavelength of light, as you see here on this patient. So there's a photodynamic reaction between the light and the photosensitizer, which has preferentially settled in these lesions. And that creates things like reactive oxygen species, and there's local destruction of these precancerous lesions. So here's an example of a patient after PDT, like the FUDX patient, a little bit of redness and crusting, and had some clearance. And again, we continue to watch these patients, and they need retreatment from time to time. When it comes to surgical management, these are our mainstay options: electrodesiccation curettage, wide margin excisions, and Mohs micrographic surgery. Electrodesiccation and curettage, it's simple, it's nice for the superficial cancers, and can be done in an office setting. We excise the visible lesion. We curette, this is under local anesthetic, of course. We curette the wound base and edges, and we use a bifurcator to cauterize the wound base and edges. And this can be done several cycles to help locally destroy these surface skin cancers. They require ongoing surveillance for a potential recurrence. Cure rates are very good with that. Wide local excisions, that's where you want to just cut around the lesion, stitch it up in one setting. And there's Mohs micrographic surgery. In Mohs micrographic surgery, we save this for our more complex tumors or ones that require tissue sparing. It's a margin-controlled excision of skin cancer. We excise the tumor, We assess its margins while they're in the office, and reconstruction is carried out the same day in most cases. High cure rates. It's very resource intensive, as you'll see, including you need to have a histology lab and trained, specially trained nurses, histotechnicians, and have the appropriate fellowship training. This is a picture of Dr. Fred Mose, after whom this procedure is named. Just some common misunderstandings I get. Mose is not an acronym, doesn't stand for anything. And sometimes I have patients thinking this is mole micrographic surgery. It's nothing to do with moles, it's Fred Mose. So when would I use Mose surgery? Tumors that are recurrent, so that's implying that they have subclinical roots. You know, it's a tumor around the eye, the nose, the lip, where you want a tissue spare. You can't just cut out a whole bunch of tissue. Histologic subtypes. We saw some of these more aggressive types of basal cells or squamous cells. Margins are indistinct. Areas of previous irradiation can hide tumors. And the immunosuppressed population are also can benefit. They have aggressive and subclinical tumors, as we've seen. So here's an example of a tissue map where if I find tumor, I will go back and take a little more until we can clear the margins. Here's a few snapshots I took of things that go on in our clinic. You can see there is a map with a tissue. We have the histotechnician. They're skilled in helping us to create those slides. There's special stains we use. We have a cryostat, which helps us, a cryotome to help us create those slides. I read the slides, map them out. We go back, cut more if we have to, and we track these tumors out. And we've already seen a few of these. Just to recap, we track tumors out. We make sure margins are clear, and in many cases, we're able to reconstruct these under local anesthetic with good functional and cosmetic results. Let's talk about systemic therapy. So, is there something I can give my patients to help reduce the number of skin cancers that they get? There are two interesting candidates, nicotinamide and acitretin. Nicotinamide is vitamin B3. It enhances the repair of a UV radiation-induced DNA damage. It reduces the cutaneous immunosuppressive effects of UV radiation. And I say possibly, and I'll explain why in a second, reduces the incidence of keratinocyte skin cancers and precancerous actinic keratosis. We were very excited in around 2015 because this came out, and there were very encouraging studies that, 500 milligrams twice a day, well tolerated, 23% reduction in cutaneous squamous cell carcinoma versus placebo over a 12-month period. Further studies were very favorable as well. A more recent phase 3 trial just came out in June of this year, didn't reproduce this finding in transplant patients. The study has been criticized for an insufficient power. Further studies are needed. We still see this as a promising option for our patients. It's affordable. It's got a good safety profile. Does not change the baseline immune response. A lot of transplant centers still encourage this. In a survey of most surgeons in the U.S., about 3/4 use this on their patients. In the UK, about 20 to 23% of the transplant center doctors still give this out. Acitretin is an oral retinoid that's been shown to have chemoprevention properties as well. Randomized controlled trials have shown up to 42% reduction in the numbers of squamous cell carcinomas in renal transplants. This has side effects, these retinoids. They cause skin dryness, they can cause alopecia, elevated triglycerides, liver function test elevations. So tolerance can be an issue. When patients stop taking the oral retinoid, they start getting rebound cutaneous squamous cell carcinomas. It's like everything that's been held back suddenly starts popping up again. More recently, low-dose acitretin has been shown to be promising. There was a good reduction, and the low dose seems to be more tolerable. So this is something that I consider in those patients with the accelerated numbers of cancers, and I want to throw everything at them to help stem this onset of skin cancer. So this is another option that I strongly consider in my patients. Sometimes we get to the point where we've done our best, and these tumors are just bad for the patient, and they metastasize, they spread. And unlike some of the images I showed you from the past, we now have some new exciting options coming up, and I like to keep up with these. There's PD-1 inhibitors, a type of immunotherapy that's been shown to have some promising results for a locally aggressive and metastatic squamous cell. In 2018, cemiplimab was approved by the FDA. In 2020, pembrolizumab was approved for squamous cell carcinoma. And you can see the efficacy, 40 to 50% response rate. So it's something that we didn't have in the past, something that we now consider for our patients. This is a patient from about 7 or 8 years ago that I first met. He developed an aggressive squamous cell carcinoma. He's a renal transplant patient from 1986, had a second transplant in 2006, has been on chronic immunosuppression all this time, developed a rapidly growing nodule. It was rather aggressive. He was chosen to have ENT look after this under a general anesthetic, wide local excision, and repair in about 2017. It cleared the margins. Had another recurrence the year after, another resection, cleared the margins. 1 year later, another recurrence. This time they added radiation therapy and more standard chemotherapy with they used cetuximab. Unfortunately, in 2019, he had regional metastatic disease. You can see it spread to the other side of his scalp. He was not interested in any more surgery. He was treated with radiation therapy, and this time they added the PD-1 inhibitor, cemiplimab, and thankfully he did well. I saw him a month ago, about 3 weeks ago. He's doing very well. He was very happy. And when I told him I was going to use his pictures, he said he was very happy about that too. We still watch him very carefully, and the use of cemiplimab, thankfully, in his case, was not detrimental to his renal functions. The nephrologists followed him very carefully, and at this time he's doing well. So efficacy is promising. Objective responses are seen in at least almost a third of these transplant patients. We would use this with extreme caution and for extreme catastrophic cases of metastatic squamous cell in these patients. You know, in the past, immunosuppression transplant patients would be an automatic exclusion to these trials, but thankfully there's a few active trials right now going on in using these special medications in these specific set of patients. So modifying immunosuppression. So certain immunosuppressive agents are more aggressive and inherently more carcinogenic due to their effects of DNA. One study showed, changing azathioprine to mycophenolate in lung transplant patients reduced squamous cell carcinoma risk by 76%. There are other studies like this. This was summarized in a recent dermatology review article. And as you can see here, drugs like the calcineurin inhibitors like cyclosporin and the thiopurines like azathioprine are considered higher risk for cancer formation, whereas mycophenolate and mTOR inhibitors like sirolimus are almost chemopreventive. So is there a safer immunosuppression? We know that mTOR inhibitors, which are a class of immunosuppressive drugs, have not only the anti-rejection quality, but they also have anti-neoplastic effects. Studies have showed 25 to 40% reduction in further cutaneous squamous cell carcinoma risk over 2 years when you convert from calcineurin inhibitors to mTOR inhibitors like sirolimus. This effect seems to be good when your patient has just one squamous cell. When they start having multiple squamous cells, this conversion doesn't seem to be as valuable. Sirolimus does have adverse effects, as we know, proteinuria, pneumonitis, wound healing issues, hyperlipidemia. A meta-analysis of 21 trials found that mTOR inhibitor the treatments had a good reduction in squamous cell risk, but there was increased risk of mortality, not from graft failure, but infection, cardiovascular disease. When they did subset analysis, they found that this was dose-related, and you still get the good anti-neoplastic effect without this adverse effect with lower doses. So it's a balance between organ rejection and malignancy risk. So as you've seen, we've we've looked at the burden of aggressive skin cancer in these transplanted patients. I've had a chance to share with you some of the images of aggressive skin cancers. We've looked at issues with photoprotection, with screening, and some pearls on managing these patients. So that was it for me. Thanks for attending. And
thanks. It was fascinating discussion and presentation and an important area that I don't think we recognize enough. I just wanted to kick it off by asking a little bit about mechanisms. So, we've known historically with transplant patients and immunosuppression of any kind that there is that higher risk of all types of malignancy. First of all, is there evidence that there's more, sort of something else going on in terms of causing skin cancers as opposed to other cancers, is the first part. And the second part is, in terms of mechanisms, I mean, you alluded to some viral etiology for example, Merkel cell carcinoma. Any evidence that there might be some, viral causes in that immunosuppression? And I do have a third part, okay, which is about biologics. And have you kind of gotten into that area of seeing increased rates with other uses of immunosuppressives, not necessarily with transplants?
Right. Thanks for the question. So first of all, regarding why these patients have higher risks of skin cancer. So it's specific to skin cancer. First of all, I think it's there's an interplay of many causes: the UV radiation, the drugs themselves, the drugs that we use for transplantation, the effects they have on you. They have inherent mutagenic effects themselves. So cyclosporin, for example, not only numbs the immune system from surveillance, but itself is carcinogenic. These drugs cause increased photosensitivity. So again, it's a skin-specific risk. And then, I guess unlike internal cancers, we have that UV exposure that internal cancers don't have to worry about. So, and skin cancers in general are higher than other internal cancers. So I think that helps us understand why skin cancers is the most common and one to worry about. And as far as specific, other causes, the transplant drugs are one big cause, but you're correct. There's other issues going on. The host genetic factors. That's why the fairer skin. You've got we talked about the UV radiation. There is a role in oncogenic viruses. So, for example, in squamous cell carcinoma, human papillomavirus is considered having a role in the process. When you look at studies, it seems to be more of an initiator of these skin cancers. In cancers like Merkel cell carcinoma, polyoma virus is implicated, so you have that. Another example is Kaposi sarcoma. I know I didn't talk about it, but the human herpes virus 8 that's implicated there. So the viral related tumors are certainly of a higher risk. So there's definitely a role in viral the virus is playing a role in these patients. So that was the question about the role of viruses.
And the biologics.
The biologics. So
yeah. So in other conditions.
Yeah. So biologics, thankfully, they don't have this high risk that these immunosuppressive drugs have. So we're still careful with our biologic patients as far as screening them. A lot of these are actually very new, so perhaps we'll learn more with time. But as of now, the skin cancer risk with the biologics is not to the degree that we see with our conventional transplant drugs.
Dr. Banji actually had an excellent question around dosing. So you talked about specific drugs and the effect, and risk. But she was asking about the patients you showed, for example, with multiple lesions, whom you biopsied and treated with multiple times. Was immunosuppression adjusted, and is there a role for that?
Over the years, when I get to treating these cancers with these patients with accelerated rates, I've had the privilege of picking up the phone and calling our colleagues in nephrology or lung transplant, whatever, and we have this discussion about your patients really accelerating in their cancers, and we have that discussion about is there any way You can tweak down the immunosuppression. And I know that they have a tough job because you've got to preserve that graft function, and I've got to look after their skin cancer. But it's definitely immunoreduction and modulation is definitely a strategy we want to optimize.
I'll just ask if there's questions in the room. So VJ first, and then I'll go.
Thank you. That was fantastic. My question is a follow-up to Narman's is in the non-transplant. Like I like the slide you had about phenotype, tacrolimus, and sirolimus and the relative risk. But thinking about like rheumatologic GI conditions, which patients? I mean, we should screen everybody for skin cancers. We don't do a good job. That's fair. But of these other drugs, methotrexate and all the other things that are used in these fields, which ones are higher risk? So obviously, azathioprine is one. But what are ones that us general internists and subspecialists should probably be thinking screen more often for skin cancer?
So, great question. And today's talk was on transplant patients, but you are right. This same effect is seen in, say, our GI patients. I have a good following of GI patients. They've been on chronic Imuran for their inflammatory bowel disease, and they're having actually the same issues. So azathioprine. So a lot of the drugs that affect the DNA damage. The thiopurines. So azathioprine, for example, is a big one. It's calcineurin inhibitors. So cyclosporin is definitely concerning. Tacrolimus a little bit better, but still has that risk. Mycophenolate a little bit less. Sirolimus, as we talked about, has an almost chemopreventive effect. There was a recent review in our journals about other drugs, methotrexate, for example, as an antimetabolite. It's not in the same category of cancer risk as these drugs. So if I won't go through every single drug, but definitely there's a hierarchy of what's bad, and the short list is the calcineurin inhibitors and the thiopurines. I would say those are the big flags. When I like to know how you've been on it and for how long. I have been seeing a trend that some of our transplant colleagues are shifting away from that to other cocktails that avoid some of these drugs.
Dan, and then Noli.
First of all, thank you very much for looking after our patients for so long, and please don't retire. So, a couple of comments. One is that we have been running lower immunosuppression. We've moved, of course, from cyclosporin to tacrolimus in most of our patients. We're running levels that used to run between 8 to 12 to now 6 to 8. Because we have better immunomodulation, but also monitoring that we can actually do with looking at antibodies and so on. But with that said and done, going back to the sirolimus bit, one of the concerns we always had about switching to a CNI-free regimen, because the rejection risk does go up. We still do that in some cases like PTLD and more solid organ cancers and things like that. But we haven't done that in the skin cancer population. So the question I have is one, if we use a lower level of tacrolimus, which we can use if we use in combination with sirolimus, for example, does that have the same or at least some benefit as compared to switching to full CNI-free regimen using sirolimus as a killer? And the second question is, photopheresis is something we use in our patients for different types of issues, rejection recurrence, but also malignancies as well. We don't have it available here, so we send it out to Calgary. Is photopheresis a possible therapeutic regimen or therapeutic approach to patients who may have these very aggressive cancers that perhaps are heading towards some of the more aggressive immunosuppressive therapies that we use?
Sorry, do you mind repeating? Just or rephrase.
No. Thank you, Daniel. So the first question about modification of the immunosuppression. You talked about if the CNIs are that bad, why not reduce them and add something better like an mTOR inhibitor with sirolimus. So there's no hard evidence that yes, if you do this, but when I think through your approach, I would say that it's as long as you're happy from the transplant physician point of view, this will help. We're reducing a drug that we know is rough on the patients from the cancer point of view, and you're adding another one that has some chemopreventive benefits. So I don't have a firm paper to support what you said, but theoretically it makes sense. And I would say, as long as it's safe for your patient, I would anticipate we would be nice to see how these patients do as long as they're safe during the transition. Your second question was about photopheresis as a therapeutic option for these cancers. It's not. I have not heard of that being used for skin cancer prevention. I think the closest thing is the PDT that we talked about. But no, I have not heard of photopheresis as a therapeutic modality for widespread cancers. So.
Well, thanks a lot for that presentation.
You might have to turn it on.
And so I really appreciate you sharing that case of the PD-1 inhibitors that we use for the squamous cell carcinoma. I know with our transplant patients, we usually shy away from using immune checkpoint inhibitors because of the risk of infection associated with it. Is that case specifically, or in cases where you use PD-1 inhibitors, did you have to do anything different in terms of immunosuppression and kind of increase it to increase the risk of infection?
Sure. So the question is when we use if and when we use these novel PD-1 inhibitor immunotherapies on our transplant patients, do we have to do something differently about your immunosuppression? So protocols are now evolving, and there are case reports that show that you can get better success of treating their cancer and preserving graft function if you do certain things. And one of them is to put them on higher doses of prednisone during treatment. That's one. And another thing is, if possible, as we talked about, converting them to sirolimus before doing this, if it's possible. It's not always easy to do. So those are at least two things that I would recommend now for the next patient that we have to think about this. And of course, the teams carefully monitor the patients during this treatment. But yeah, basically intensifying the short-term immunosuppression is the key thing to do. There are actually trials now, and like I said, in the past, it would be an automatic exclusion, transplant patient, nope, not included. But we have specific trials that are actually looking at that very question that you asked, where they're going to take these patients, put them on combinations of PD-1 inhibitors and various doses of prednisone, for example, and see how they do. So hopefully we'll learn more.
I'm just going to go to the online questions a little bit. So the first one is, most of the patient photos seem to show older patients. In the app, they only ask about age at transplant, not age of the actual patient. When you're screening them, how much does patient age factor into risk, or is it just age at transplant that seems to be the risk factor?
So the data, the app was based on pretty strong data. So the fact that they found that as the cutoff, that's what I would use. So age at transplant, 50 years old, seems to be a good benchmark. Obviously, if I have an older patient, they've probably had more sun exposure, so that's a risk. But as far as risk stratification, I still use that as the benchmark. Older than 50 years old, check mark. I'm going to give you a few more points on that scoring tool. But age is, we certainly see more in the general population. We see more cancers in our older patients, so it's definitely more so in the older patients.
Something to consider, yeah. Dr. Armstrong's great presentation. Precision medicine with genotyping appears to have enhanced outcomes in some melanomas. Has similar progress been made with squamous and other skin cancers?
So it's true the melanoma patients have benefited greatly from this. As far as genotyping, for the squamous cell carcinoma patients, they have figured out gene profiles of patients that have a higher risk of squamous cell. So the answer is yes. They look at these gene profiles, and actually they're not mainstream yet, but in the United States, you can actually get you can order gene profiles on your squamous cell carcinoma patients. It's done by a private company, and that can help you stratify higher versus low risk. So absolutely, it's in the squamous cell population as well.
So it's not commonly used in Canada, or
it's not commonly used in Canada. In our conferences in the United States, they talk about doing the GEP profile on this case and see if they're at higher or lower risk. It hasn't entered into our mainstream use yet, but it's there. There's gene profiling as a marker for risk.
A surgical question. Great presentation and thank you from Dr. Liu. Do you worry about wound dehiscence or impaired healing in patients on MTOR inhibitors that need to undergo Mohs? Would you recommend either stopping MTOR inhibitors beforehand or delaying initiation until patients have healed from the Mohs?
So thank you for the question. So one of the side effects of mTOR inhibitors is delayed wound healing. For the surgeries that we do, generally speaking, they're localized. So we don't worry too much about those mTOR inhibitors. If it was a significant case that I thought might require significant reduction in ENT reconstruction, then I probably would call you up and have a discussion. But generally speaking, no, we don't worry about, for our local flaps and grafts, we don't worry about modifying or stopping sirolimus.
Dan has another question.
Unless somebody else has got another question.
No, you're good.
Oh, thanks.
I don't know if it's working or not.
So, as you know, we used to use NAS a lot in cardiology for a number of years. And then we were using also non-transplant patients from the things we talked about, whether it be from a skin cancer perspective or whether it be for CAV prevention. Since niacin has fallen out of favor in cardiology, we kind of stopped that doing in the transplant patients as well. Based on your presentation, it seems like there may be a benefit to being back on niacin or niacin-like analog. Would you now recommend that we go back on the transplant population to having our patients on niacin on a regular basis?
So that's an interesting question. Yes, I guess niacin.
Can you repeat?
Oh yeah.
Sorry.
So thank you, Daniel. He's asking about niacin, which used to be used in cardiology, I believe, for lipid lowering, correct? And it's fallen out of favor. And now that I talked about nicotinamide, should they start using that? So my understanding is nicotinamide and niacin, they're actually different enough that it's the benefit is specific to nicotinamide and not niacin. And we've had anecdotes of my patient calling me because I prescribed nicotinamide, but suddenly they're flushing. And that was because they were given niacin instead of the nicotinamide. So it's actually specific to nicotinamide. So no, I don't think we can justify, going back.
Would you recommend using nicotinamide in our patients currently?
Yes, that could be used. I don't know the data on its effect on lipid lowering, but if you think it's as good as the next product, then I would say it would help your patient's lipid profile and my patient's precancers.
Particularly in high risk, right?
In high risk, I save it for my high risk patients. As far as I want to throw everything at them that I think will help reduce their risk. So.
Or with potential genotyping in the future.
That's right.
It was really an excellent talk. I mean, there's lots of people in the audience, and we had like over 100 online. So
Terrific.
Obviously a very important topic and really well done. So on behalf of the department, thank you, and we look forward to hearing more from you.
Thanks, everyone.